Rise to the pledge. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good afternoon. Welcome to the February 11th, 2026 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, if you could call the roll.
Director Nicholson?
Present.
Director Yee? Present. Director Stewart?
Present.
Director Eapen? Director Wallace?
Present.
Thank you. We'll now move on to oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Seeing none, Cheryl, are there any written communications?
There are no written communications.
We'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Seeing none, does any member of the public want to remove an agenda item from the consent? Seeing none, may I have a motion to approve the consent calendar items A through E?
I move that the Board of Directors approve the consent calendar items A through E.
Second.
We have a second from Mr. Wallace. Cheryl, if you could do a roll call vote.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Eapen? Director Wallace?
Aye.
Thank you. The next agenda item is our presentation, Cardiac CT Surgery and Structural Heart Program. Kimberly, if you'd like to introduce our speakers.
Thank you. It's my pleasure to introduce our two speakers this evening that many of you are very familiar with. The first is Dr. Ramin Beghi. He concurrently joined UCSF School of Medicine faculty in the Division of Adult Cardiothoracic Surgery and assumed the position of Medical Director of Cardiothoracic Surgery at Washington Hospital in May of 2016. He has practiced cardiac, thoracic, and vascular surgery for over 22 years at UCLA, Stanford, and the UCSF medical centers, and has been practicing the entire scope of his experience and expertise. He has served as the Director of Thoracic Aortic Aneurysms at UCLA and the Surgical Director of Lung and Heart Lung Transplantation at Stanford University Medical Center and Lucile Packard Children's Hospital. As Medical Director, Dr. Beghi is assisted with the development of a full range of cardiothoracic services locally to meet the needs of the community, and he will be talking about some of them this evening. Our other speaker this evening is Dr. Harsh Agarwal, Medical Director of Structural Heart Program. He started working at Washington in 2021 as part of a TAVR procedure team from UCSF. He built relationships with local cardiologists and began to help them manage their patient's structural heart disease and to perform procedures such as mitral clips, Watchman device insertions, CFOs, and complex PCIs in the cath lab at UCSF. He has served as the Associate Cardiology Fellowship Director at UCSF as well as the Assistant Professor in Structural Interventional Cardiology. He continues to practice interventional cardiology and structural heart at California Pacific Medical Center and at Washington Hospital. All right, we'll turn it over to you, Dr. Beghi.
Thank you very much, Ms. Hart. Ladies and gentlemen, it's a privilege to be here. I just wanted to talk about the theme of our program, which is Advanced Care Close to Home. Thank you very much for the first slide. As you know, the cardiothoracic surgery at Washington Hospital started in 1986 with the late Dr. Robert Pipkin. I had the privilege of having worked with them when I was a vascular surgery resident at Stanford. I actually assisted both Dr. Pipkin and Dr. John Thomas Mahegan, who also worked here for a long time. In 2016, I had the privilege of being recruited by UCSF jointly with Washington Hospital to be the medical director of the cardiothoracic surgery program and also faculty at UCSF. The following year, November of 2017, Dr. Lee joined us, and then our program continued to develop and evolve. In 2025, the census shows that our hospital has 415 beds and serving a community of over 400,000 people and perhaps beyond. And we have performed over several thousand cardiothoracic surgery cases at Washington Hospital. If I could have the next slide, please. So our team is Dr. Teng Lee, on the cardiac side, Dr. Teng Lee and Dr. Art Hill jointly help us cover the program. Dr. Lee and I perform the majority of the operations on the cardiac side at Washington Hospital, and Dr. Hill also has shown interest and expertise in helping with the thoracic trauma and assistance in the structural heart programs. Dr. Hill is also faculty at the UCSF. So the three of us are able to cover all the cardiothoracic surgery cases at Washington Hospital, urgent, emergent, and elective. So this scope of our program is very extensive. Great majority of our cases, something like 3/4 of our cases, are coronary bypass grafting cases that have evolved and become more complicated. We perform valvular heart surgery cases, both open and surgical aortic valve replacement, and help Dr. Harsh Agrawal with the transcatheter aortic valve. We perform mitral valve, tricuspid pulmonic valve operations, aortic aneurysm dissections, both open and endovascular, and both urgent, emergent, and elective for a type A dissection. We have also expanded our practice to treatment of atrial fibrillation for patients who are not responding to medical management or transcatheter procedures to close the left atrial appendage to reduce the risk of stroke, and a MACE procedure. We also have performed and will continue to perform operations for congenital heart disease, adults with congenital heart disease, coarctation of the aorta, pulmonic valve disease, adults who have previously undergone surgery for congenital heart disease, like tetralogy of Fallot, also have received the subsequent operations here at Washington Hospital. Our volume, with some oscillation between years, has continued to expand. We are projected to have about 200 cases for the projected in fiscal year 2026. That includes the totality of our program, cardiothoracic surgery program, on-pump and off-pump transcatheter valves that we do combined with the structural heart program with Dr. Harsh Agrawal, thoracic surgery, some vascular cases, and open and closed aortic aneurysms and dissections. So I believe that we will have the highest number that we have had for a long time by the end of the fiscal year 2026, approximately 200 cases. Our clinic also, we see a very large number of patients in our clinic and evaluate them for surgery, both preoperative evaluation, postoperative evaluation, and subsequent follow-up, and also arrange for them to undergo surgery. Our approach has been to have a rapid access for care. Still about 2/3 to about 3/4 of our patients are urgent or emergent. They are still in the hospital when we operate on them, but some are referred to our clinic for evaluation. Our plan has been to see them within 7 days of referral, so they can get to our clinic for evaluation within 7 days. And after being seen in the clinic, usually within 7 to 10 days, we schedule them for surgery in the operating room. And then we have a post-discharge follow-up to improve our quality of care and reduce the number of referrals back to the emergency department. Our team contacts the patient within 24 to 48 hours of discharge to assess how they're progressing at home. We have a comprehensive ambulatory coordination that we have post-op communication with the referring cardiologist and primary care doctor, and referral for specialty care services. Postoperative cardiac rehabilitation is an important part of our practice to make sure the patients, after being in the hospital for a complicated or a complex heart operation, they have a good referral. So every single patient is seen at the hospital with an ambulatory team for follow-up cardiac rehab evaluation and referral to be done usually within 5 to 6 weeks of discharge from the hospital. If you look at our number of our cabbages, this is actually not the totality of, because this data for the STS goes for calendar year, so it's through September of 2025. We have a few benchmarks that we wanted to achieve. So the readmission within 30 days is one of the benchmarks, and the goal is usually around 10%. And in 2025, we reduced our readmission to 7.8%. We had a bit of a rise in 2024, but in 2025, it was down below 10%. Any complication that include atrial fibrillation, admission, stroke, mortality, morbidity, and all sorts of complications that are reported to Society of Thoracic Surgeons, our rate was 33%. One-third had complications, which is below the benchmark of 38%. And our postoperative length of stay is usually the goal is around 6 days or less, and we have attaining that benchmark as well as 6 days post-hospitalization discharge. Our patient demographics are quite different, though, from the Society of Thoracic Surgeons reported. About 53% of our patients are over the age of 65. Our patients tend to be younger than about 61% that are over the age of 65 on the STS database. That actually, ironically, does increase the complication of the cases. Younger patients with coronary artery disease at a young age, they tend to have more complicated comorbid conditions that would make the operation somewhat more complicated, and that has been documented on a variety of reports. The number of male to female is very similar to the STS, somewhat less. We have about 21% of our patients are women for coronary artery disease, and on the STS are about 22%. Our race and ethnicity is very different from the STS. Only about 14% of our patients are Caucasian, and about 2/3 of our patients, as most of you know, are from Asian background. So that also does add complexity. In the STS database, only about 4.8% of the patients are Asian, and about 78% are Caucasian. But we do not see that trend in our hospital, which is representative of our community that the Washington Hospital serves. Just a few things about our program highlights. We, as I mentioned before, we continue to perform complex cardiac surgeries, coronaries, and valves, and we report our results to Society of Thoracic Surgeons. For the multi-procedural outcome, we actually attained a 3-star outcome. 2-star is what is expected, and even if you have a 0% mortality for some of these programs that the numbers may be small, we will not be given a 3-star. But for the multi-purpose overall program, I think we had enough of numbers that we actually attained the 3-star stratification by Society of Thoracic Surgeons, which is a good accomplishment and is well recognized. I just have to say, no hospital in the Bay Area, academic or otherwise, have attained the 3-star classification by the Society of Thoracic Surgeons. So achieving that is a credit to our program that I will describe briefly in a second why it does. We have also, because we do have a helicopter pad and we have access to transferring patients, we do manage to bring patients from other places. You know, with the starting of the trauma program, that was also very important. The case in point that actually was advertised in some publications locally, it was New Year's Eve in 2025, an 80-some-year-old woman who's actually mother of a nurse, was admitted to and a resident of Petaluma, California, was in a local hospital with an acute type aortic dissection. And no hospital in the Bay Area, academic or otherwise, was able to take that patient, including the hospital where her daughter works as a nurse and has a cardiothoracic surgery program. We brought the patient by helicopter to Washington Hospital after multiple places had been contacted, and then eventually we operate on her. And this is a picture of her after surgery, and this is the woman in the middle with her husband to her right and a daughter to her left. That had surgery done at Washington Hospital, complicated type A aortic dissection, and fortunately did very well. And ever since, I've been following her along. So we are able to bring in patients to Washington Hospital. This is actually one resource that we haven't overutilized yet, but I'm hoping to be able to take advantage of the fact that we can bring in patients to Washington Hospital that would normally be referred to other medical centers, predominantly Stanford and UCSF, and take care of them here at Washington Hospital. What are the hallmarks of our program? Our program, we are able to produce good results for several reasons. We have a 24/7 intensivist, two intensivists who are in the hospital at all times and can take care of our patients. We have a dedicated cardiac anesthesiologist who are trained in cardiac surgery and to perform intraoperative transesophageal echocardiogram and do have experience and expertise in managing patients who undergo cardiac surgery. We have a dedicated cardiac operating room who can take care of our patients, both elective and emergent. We have launched an advanced program in transcatheter aortic valve replacement. As it was mentioned, Dr. Harsh Agrawal, who was a fellow at UCSF and subsequently on faculty at UCSF, joined us. And since 2021, we have been doing transcatheter aortic valve. This will be discussed later on by Dr. Agrawal, but that has expanded to other structural heart programs that also affects our program. We have a comprehensive trauma services that we can help and support in thoracic surgery trauma, cardiac trauma, vascular surgery trauma, and we have treated those patients as well. Our plan is to proceed with the robotic CT surgery. Robotic CT surgery predominantly for the mitral valve repair, we may have a role. Still, the great majority of the patients may undergo other procedures, including mitral valve clip, mitral valve surgery in a structural standard fashion. But robotic surgery would be a good addition to our program, that certain patients who would be good candidates to have the procedure done through the robot. There would be also a way for us to advertise and publicize our programs that we provide those kind of services. We have a hybrid cardiovascular hybrid operating room that we can perform structural heart programs, transcatheter procedures, as well as endovascular procedures. And we have also cardiac care close to home as our logo, that we are letting the patients know that we can provide the totality of their care here at Washington Hospital, and for the programs or for the services that we don't provide. For example, heart transplantation or end-stage heart and lung disease, we have connection affiliation with the UCSF that we can provide those cares over there. Dr. Lee and I are on the cardiac side, and we also have, in addition to Dr. Agrawal, who will be speaking after me, we also have two electrophysiologists from UCSF, and also Dr. Mandar Aras, who is a heart failure cardiologist, who also see and evaluate patients on site within 1 or 2 minute walking distance of the hospital in our clinic for further evaluation and care. With that, I would just leave the podium to Dr. Agrawal, and I'll be happy to answer any questions should there be any.
Thank you. Any questions for Dr. Baby? No, thank you, Ramin. Let's hear from Dr. Agrawal.
Thank you very much.
Thank you, Dr. Beghi. I'll be, quick and precise, but thank you for having me. It's a privilege. And thank you, Dr. Beghi, for introducing us. As you know, our structural heart program is going on since 2021. We provide minimally invasive catheter-based treatments for complex heart valves, structural heart disease, as well as coronary artery disease for high-risk elderly patients. And faster recovery who are not good surgical candidates. So that's our mission. Next slide. What we provide here now has expanded exponentially. We provide transcatheter aortic valve, mitral valve repair, replacement, balloon valvuloplasty. We have a tricuspid program. We are launching our tricuspid replacement program in March, and we have a valve-in-valve procedure. We have a left atrial occlusion for patients with atrial fibrillation who cannot be on blood thinners. And then we do some congenital devices as well as ASD, PFO, and paravalvular leaks, which are very, very specialized. Next slide. Our procedural volumes, thanks to the community, our referring physicians, our CT surgery colleagues have grown. We are a slowly growing program, trying to maintain our volumes. As you see, by January 2026, we had a total of 330 procedures. Most of them were cardiac catheterization, but structural heart did exponentially grow from 14, 126, 79, and even growing more in total to next year. Next slide. We are reporting in all clinical registries as mandated by the FDA, all the ACC, STS Society, and TVT is the transcatheter valvular registry for our outcomes, oversight, quality, safety, and compliance. I should mention that we see more patients and we refuse them than we do them. So that's something that has to be really recognized. If we see 100 patients, I think 20 of them get procedures and 80 of them get sort of don't, because of, just what at this point we can provide with quality, safely, and compliance. We have CMS coverage, site requirements that we perform. Every patient is reported in a registry, and every outcome is transparent. So that's how we maintain our programs. Next slide, please. So, our clinic volumes have expanded from 600 to 1900 until currently 1100. We are on our way to expand clinic referrals, which is thank you to our community colleagues, obviously our primary care physicians, our referring physicians. We've grown with their help, and they see that we do good work at Washington Hospital. Next slide. Tower volumes have definitely grown. We started with 4 towers. We're currently around 58. That's the real number. We've done 35 already since January. So we will be a medium-sized tower program. Any tower program about 40 towers to 90 is considered a medium. Anything between 100 to 200 is larger, and anything above 250 is a massive tower program, which is only 4 or 5 in the country. So we are in the medium quartile of towers. Next slide, please. Patient demographics remain pretty much the same. We do a lot of above 85-year-olds. It's 32%, which are higher risk. And as Dr. Begi had mentioned, our demographics are a little bit different than everything else. As you can see, we are European. Your colleagues are 21%, and unknown, which is more Asian than anything else, is 26%. Next slide, please. So as you can see, it's been a long journey, and thanks to all of you, all our community colleagues, and all our referring doctors. We started with a TAVR. We started with left atrial appendage occlusion. We admit all of them. We began a mitral program. We included all the CAT scans. So now we can do a CT for the mitral valve, tricuspid valve, aortic valve, as well as left atrial appendage occlusions. So all the CT capabilities are staying at Washington Hospital. These CTs all of them are going out to Stanford or CPMC or UCSF. So with the help of our radiology colleagues, we have implemented all the protocols. For the coronaries, we have a new drug-coated balloons. We started a tricuspid program, our transcatheter mitral valve replacement program. And we are starting our tricuspid replacement program, which is a transcatheter valve called Evoke for high-risk patients in March of 2026. So a lot of excitement coming in. Next slide, please. And as I said, these are, just showing off what we did, but we select lesser patients than we can be referred to because our selection process is very rigorous. We are very thorough because we have to meet the industry registry standards. So, a lot of patients get rejected, unfortunately, and that's how it is. And you have to realize these are high-risk patients which are not the best surgical candidates. So even at baseline, they are higher risk. So and we have to be very selective in our process. But we want to help most patients. We want to help people live longer, have a better quality of life, and not leave Washington Hospital, where we can provide the same level of care at any other academic institution, which we currently are. Except, obviously, 3 of my patients got transplanted at UCSF this year because we send them there, and that's how our collaboration works. But most of the stuff, as Dr. Begi, Dr. Lee, Dr. Hill said, we can provide with at Washington Hospital safely, efficaciously, and have very good outcomes. So thank you, everyone. Next slide. And then, this is our campaign. Thanks to our marketing colleagues. I really appreciate it. We had 1 million people reached, 3.8 million impressions, which means clicks. Everybody had digital engagements, high value reach. We bought an NBC, connected TV, Nextdoor, paid research. And, we went to as far as Alameda, Marin, Sonoma, San Mateo, San Francisco, and obviously in our Tri-City area. I've been actively trying to get our program out towards Alameda, obviously, and then Hayward, Dr. Beggy, and I have been trying to get through Modesto, and there's hopefully we can go down to San Mateo at some point. But our name is out. We are a recognized program. We are one of the highest performing mitral programs in the Bay Area currently. So kudos to all the team. Thank you. Any questions?
Any questions for Dr. Agarwal? All right, thank you very much, Dr. Agarwal and Dr. Beggy. We wish you continued success in the growth of the cardiovascular scope of services that you're able to deliver right here at home, here in Washington Township.
Just want to thank you guys and the entire team in both the clinics, in the hospital, and as you showed in your presentation, it really does take a lot of coordination of care in the ambulatory setting, in the post-surgical setting. We've got a great team of nurses in rehabilitation and cardiac rehab programs here. And these patients obviously use a lot of resources, both in the imaging areas, the labs, and on the inpatient side. Our volumes continue to grow. Our ability to support the community continues to grow because of the great work that you guys are doing. I know trauma's added to the mix too, Dr. Beggy and Dr. Lee. And then with what you've done, Dr. Agarwal and the rest of the group, it's very much appreciated. I think we've got some very well-run program here, and we're excited for the next steps. Thank you, guys.
Thank you so much for it.
Thank you.
Thank you. Do you know if Dr.
Yeah,
Berry is available?
I believe he is available.
Is he?
Yes, he's
Oh,
there.
there he is.
Yep.
Aaron,
Hi, good evening.
good evening. Did you have a good flight?
I did. It was a little bumpy getting in, but everything worked out okay, and I'm here just in time.
Wonderful. As expected. Go ahead.
All right. Well, I will give my February medical staff report. We have 13 new applicants to the medical staff. I won't go through each of those until next month once we have approved all of their applications and done our full review. But I will talk about the new members of our medical staff that joined us just this last month. Dr. Maitham Al-Kadumi is an interventional radiologist with ARIA. That's the new IR group that we've started working with just a couple of months ago. They're gradually getting credentials for more of their physicians here in Washington. We have a pediatrics nurse practitioner named Shayna Jill Sibayan Balayan. She's joining the medical group. We have Dr. Oliver Cervantes, who's a pediatric hospitalist affiliated with UCSF. Dr. Brandon Daniel Kamrava, who's an ear, nose, and throat specialist, who's based at Regional Medical Center. He's providing some call coverage for us. And I did a case with him, emergency case in the middle of the night, one night. I can say he's an excellent doctor. We have a nurse practitioner named Rajpal Kaur with the Family Medicine Department. We have Darren Tan Liam Go, who's a PA joining the Orthopedic Trauma Surgery Department. Anjali Rai, who's a PA joining Dr. Saw's practice in orthopedic surgery. Dr. Jianling Tao is a nephrologist who's with PAMF. Dr. Sean Wickers, who's a pediatrics hospitalist, who's affiliated with San Francisco General. I would also assume affiliated with UCSF. And a general surgery PA named Anne Zhang, who's joining the medical group. So with those new members of the medical staff, we are almost at 700 members. I don't think we've ever crossed the 700 mark, but we're getting close. Officially at 697, with more than half of those people being active staff. In addition to the medical staff summary, I do want to just highlight that we have a magnet nursing survey coming up in, I think it's next Thursday. And the medical staff is very eager to have those surveyors come and talk with the physician leadership at the hospital so that we can highlight all the great work that we do with our nurses and all the collaboration on projects and quality assurance and patient care that we do. I want to underscore the importance of the magnet program, which is that only the top 10% of nursing programs are awarded with a magnet recognition. And we are going for our fourth time in a row. So I think this just highlights, again, how excellent Washington Health is, the kind of quality nurse staff that we have here in our community, taking great care of our patients and working collaboratively with the physicians. That's all I have for my report, and I'm here for any questions.
Any questions for Dr. Berry?
No.
No, thank you. Thank you,
Thank
Dr.
you.
Berry. Well, I'm sure we'll cross the 700 mark this year, and I thank you and your whole team in bringing the talent to take care of our patients here at Washington Health. So thank you again.
Yeah, my pleasure.
All right. Next is our service league report. Sheila. Valentine's Day is just a few days away.
Yes, I have read on, Dr.
I can see that, but you're going to break my heart. This is the last report. Right?
Yes, it is. Yes, it is. And
I'm just heartbroken.
I'm sure I'll seek you out, Dr. Nicholson. I'll make sure you don't miss me.
Well, that's music to my ears.
All right. I'm pleased to share updates on the work of the volunteers. In January, 283 Service League volunteers contributed 3,055 hours across various hospital departments. On Tuesday, February 10th, we held our annual meeting, which was yesterday, where we reflected on the past year, recognized our volunteers, and elected the new board. Thank you to all of you, the district board members and members of the executive team who attended the event. The Service League pledged a $50,000 donation to the UCSF Washington Health Cancer Center in 2025 to be distributed in 3 installments. At the annual meeting, we presented the second of the 3 installments, which was $15,000. In addition, the Service League donated an additional $15,000 to support the purchase of a bladder scanner for the hospital. All in all, the meeting was productive, and we celebrated the past year of the Service League. I'm also thrilled to announce the beginning of a new volunteer assignment in the ED waiting area. Volunteers will now staff there, offering wayfinding and answering questions. Our first trainer for the program, Soumya Rai, shared with us that she became an ED waiting area trainer because of her EMT background and interest in emergency medicine. She told me the role is a natural fit. What I enjoy most is helping new volunteers build confidence in a fast-paced environment supported by the emergency department staff. As of today, we have 2 volunteers staffing in the emergency department waiting area. The ED can be a stressful place for patients and families, so we are looking forward to having more volunteers there to provide assistance. As Dr. Nicholson already said, this is my final report, and I want to express a few words of thanks. I'm very grateful to the district board for the support you have shown throughout my term, and it's been 3 years now. And I especially want to thank Kimberly for her leadership, partnership, and guidance, and also the hospital leadership for their collaboration. It would be remiss of me if I didn't acknowledge Angus Cochran for his support during my 3 terms, and Director of Volunteer Services, Evangeline Imana Iemura, for her guidance. And finally, I'm very, very grateful to our volunteers. Serving alongside such a dedicated group has been a privilege, and I'm leaving this role with confidence that the Service League will be strong and will do a lot of good work ahead. And that concludes my report. Please let me know if you have any questions.
Do we have any questions? I certainly have some comments. I just really want to express my deep appreciation for all of your hard work and leadership over the last 3 years that you've brought to the Service League, the new programs that you've delivered, bringing back the high school volunteers, the new ER program. These all add to the scope of services that the volunteers, we do appreciate the checks. Those are great. But what we appreciate more is the dedication and hard work that all of your volunteers do day in and day out at this facility. So, as I said yesterday, you guys are the heart and soul. You've set the cornerstone of the culture and character of Washington Health. And I think Liz has some big shoes to fill. Jill has some big shoes to fill. So I wish the Service League the best in the years ahead. So I'll invite other board members to comment.
Sheila, I really appreciate all you've done. It has been an absolute pleasure. It really has.
Thank you, Dr. Stewart.
In the business we're in and the day-to-day things that go on, sometimes it can be very, very stressful and difficult, and there are always, no matter what we do, there are always questions, problems that develop. It has been an absolute pleasure in all that you've done. But I personally, and I'm sure the school itself, is going to miss your leadership. It's been great.
Thank you, Dr. Stewart.
We have flourished under your leadership, really have. We came out of COVID kind of trying to figure out things, and you just stepped right in and shined a light and gave us good direction. And the thing that I really appreciate, one of the things I appreciate about you, Sheila, is the way that I overhear you training the new volunteers. And the bar is so high. I love it. And you are really stressing why we volunteer, who we're here for. It's not for us, for the patients, and the quality of the character that it takes to be the volunteer that reflects the culture of the hospital that we want to attain and maintain. You start building in these young college kids that are just starting their career in healthcare. They're going in lots of directions. They're high caliber. They're super smart, but you're teaching them passion and compassion. And I just appreciate that about you so much.
Thank you. Thank you, Jeannie. I do feel sorry for them, though. I'm a mom and a teacher and a principal rolled into one. I would not want their schools.
They don't stand a chance. It's a good thing. It's a good thing.
I sometimes hear myself and I go, you poor thing. I'm so glad I'm not you. So, yeah.
Thank you.
Thank you, Jeannie.
Yeah, you just created just a high standard for those that are going to follow. Your energy and the legacy that you leave is just unimaginable. I can't tell you how much I appreciate it. I met you the first time in person during the Christmas, and I was amazed at your height. Because I sit here in this room and I'm always looking up to you. And notwithstanding your actual stature, I can tell you that I will always look up to you, no matter where you are.
Thank you, Mr. Wallace. That just shows you should never underestimate small people. Thank you very much. All your words mean a lot to me, and I know Kimberly already thanked me yesterday, and I really appreciate everything. And I think I know where all your offices are. I don't know if it's good or bad, but I'm sure I'll see you. If not anywhere at the tree lighting ceremony, I'm sure I'll be there. I'll be here for Washington Health. So I'm sure I'll bump into all of you.
Thank you.
Thank you so much,
Sheila.
Thank you.
Okay. So let's move on to our quality report with Mary Bowron, the 2025 Infection Prevention Program.
Yes, I'll just quickly introduce, we have both Mary Boron and Dr. Diane Martin that I know all of you know both of these individuals, but just to give everyone a brief summary of their background. Mary has been at Washington for 17 years and currently serves as the Assistant Vice President and Chief Quality Officer. She earned her Bachelor of Science in Nursing and Master of Science in Nursing from the University of San Francisco and completed her doctorate in nursing practice at Samuel Merritt University. She began her nursing career as a medical staff nurse and the house supervisor, serving 5 years, and then she spent 6 years as an emergency department nurse. She transitioned into infection prevention in 2009 and has taken on many roles within this healthcare system, and definitely appreciate all the work that Mary does, and she oversees many areas, including quality, the emergency department, and she is certified in infection control, lean, and certified professional in healthcare quality. I think all of us know Dr. Diane Martin. She was a member of the Washington Health Medical Staff from 1984 to 2023 and served in many leadership roles throughout Washington. She retired from Washington Health Medical Group in 2023 also, and she has continued her role as Washington's Infectious Disease Program Consultant. She serves also as the chairperson of the Infection Prevention Committee. She attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine and received a fellowship in infectious diseases at the UC Davis School of Medicine. So I think I'm going to turn it over to you, Mary, to begin.
Yes, thank you, Kimberly.
All right.
And thank you for the opportunity for Dr. Martin and I to come here tonight and discuss the purpose of our infection prevention program, what we're working on, what things we still need to improve, and some accomplishments. We do report out to you on a quarterly basis, but on an annual basis, just about the program. So some of the background, of course, is that every year it's estimated that at least 1 million infections occur in the hospital that were hospital acquired. And so because of that, it led to people and hospitals having to have a really good, solid program, which, like I said, I've been honored to be a part of with Dr. Martin for a long time, about 17 years. So the purpose, of course, is to prevent hospital-associated infections. We pull this together by using every discipline in the hospital, and we get to help us identify and control infections. Next slide. So as I mentioned, it's very important to have a strong oversight to this program. So it's multidisciplinary, and we have a dedicated committee. It ranges everywhere from Dr. Martin, myself, our director of quality, Maria's on it. We do have really good infection prevention staffing here. And again, a lot of support from every single department in the hospital to make this program work. So there are multiple components to the program. First and foremost is keeping our patients safe and making sure that the quality of care meets the standards to prevent infection. We also focus on healthcare worker safety, especially since COVID. It's been really important that we do all these prevention tactics to help prevent the patient from being harmed and our healthcare worker. We always use evidence-based policies. Every infection that is hospital acquired in this hospital has a root cause analysis done by a multidisc team. And we do annual education with all the staff, including family members. It's really important that family members understand why we make them wear a gown if their family member is in isolation, going over the importance of hand hygiene, and we have visitation guidelines that are really strict. So lots of components. We also have a lot of data reporting that we do. Our data reporting is on a federal level, on a state level, and on a local level with Alameda County. So all of those agencies get data reported, and majority of them make the data public. And it ranges from everything to CLABSI to C. diff. Next slide. There are regulations, obviously, in these programs. All your patient safety goals, we have an entire dedicated chapter with Joint Commission that we work on. And then, of course, all our data that's reported goes through National Healthcare Safety Network, which I'll get onto on the next slide. One of the main things that we have to do in this program is an annual evaluation. And we look at all the risks, we review all of our data from the prior year and say, okay, these are our accomplishments, but here's what we still need to work on. That's done on an annual basis. We just did it in November and updated our plan in January. So for 2025, we had a great year in infection control. Lots of infections prevented. C. diff was, as you guys know from when I bring you the quarterly reports, C. diff we're really doing well on, very low. CLABSI's been a huge success here, as you guys know, sustained for a very long time, not having CLABSIs. We continue to round, and those are all the important components. So I think overall in 2025, really good accomplishment on keeping our patients and healthcare workers safe. Moving into this year, we're going to continue to focus on multidisciplinary on MDROs, which is infections that can't be treated well very easily with a low-level antibiotic. So these infections are getting stronger and stronger every year, and we really want to focus on preventing anybody from getting a multi-drug resistant organism while they're here. So that'll be our big focus for 2026. And next slide. So we do have a very comprehensive surveillance program. And like I said before, it's based on what we've assessed we're at risk for, really. But we're really looking at all these upper respiratory illnesses, continuing to, of course, monitor COVID, but really keeping everything that's a respiratory infection all under one policy and preventing the spread. Device-related and prevention of infections we're going to be focused on. That's things like your CLABSI and your CAUTI, and surgical site infections, especially in high-risk surgical procedures. So the other part that's very important is infection control has to do risk assessment on all construction projects. So every time we do a construction project, it is communicated to infection prevention, and we go through and we do an assessment, and that is called an ICRA, Infection Control Risk Assessment. And we range the construction from low risk to high risk, and each area has different interventions you have to do, determining what the risk classification is. We're very strong on ICRAs here. We work really closely with other members of the team outside of our department to make sure that if we are doing construction, everybody is kept safe. The other part that's really important is water management. And it sounds like, oh, that's interesting. Why would you be so concerned with the water? Because the water is such a potential source of infection. We do monitoring with a third-party vendor to look at the temperature monitoring, bacterial testing of our water to make sure there isn't any bugs growing in there. We do this based on our plan and our protocol. And I expect that when Joint Commission comes here this year, they will look at that protocol. And we have all the data to back up what we've been doing to make sure that our water is safe here. Environmental care is also really important. We do environmental care rounds more than once a week. We look at high-risk areas, of course, like where your instruments are processed, OR, everything ranging from patient rooms to what's going on in your environment, even when you walk in and look at the structure of rooms and things like that, because those areas and equipment can sometimes can harbor pathogens. So environmental care is very important, and I feel like we have a very solid EOC program here, and shouldn't be running into any problems related to that. I'm going to move this next part to Dr. Martin, who is an absolute subject matter on antimicrobial stewardship and has been running it since it started. So I'll hand it over to Dr. Martin.
Thank you, Mary, and thanks to the board for letting us present this information, because I think it's very important we do it within the hospital, but also to let our communities know what we're doing and how we're trying to help both the hospital as well as our community. And it's also a pleasure to follow Mary Bowen, who's been one of my mentors for many, many years. So the Antimicrobial Stewardship Program was started in 2010 to monitor and evaluate antibiotic use. We basically follow direction with two pharmacists that are both PharmDs who have been very instrumental in getting this program up and running. One is Mintu Denon and the other is Cindy Lau, who have been tremendous help with this program. The program is interdisciplinary, so we have both pharmacists, but we also have other team members from physicians and from nursing staff. We have a a dedicated pharmacist, as I mentioned, which also reviews usage in cases. We have drug usage, which we evaluate, in other words, try to look at what we call high risk. And when we say high risk, what we mean is those that might lead to a second infection, which I'll go through in a little bit more information, called Clostridium difficile, but also they are high risk for inducing resistant infections, which sounds a little paradoxical, but sometimes that's what happens. So our drug use is evaluated very carefully to make sure that we avoid those risks. Our team also includes infection preventionists, two of which were mentioned already by Mary Boland, Shivali Desai, and as well as Anusha Chakravarti. And also, we're very happy to have Maria Nunes as our coordinator. We also have several of our hospitalists participating in our stewardship program. We have lab and micro staff, as well as nursing, as well as IT. We look at usage guidelines and education and provide that to our stakeholders, which are primarily the nurses, physicians, as well as administration. Again, as I'll go to in a little bit more detail, we do C. diff infections, screening and treatment algorithms in collaboration with infection prevention. We also do physician engagement with regular reporting to our medical staff and our department meetings. We have multidisciplinary teams to evaluate, update, and recommend any education to the general medical staff, which is usually done through meetings. Next slide. So looking at our 2026 triple epidemic planning, which I'll get to on the next slide. So endemic means that this is a disease that's occurring regularly in an area, region, versus pandemic, which is more that's overall, not a word, overall worldwide. Influenza is surging in California, especially influenza A. So we have increased our use of PPE, which is personal protective equipment, which refers to gowns and gloves, as well as our masks. We're updating our healthcare worker mask policy. We're also doing self-attestation for respiratory symptoms for visitors and the staff when they are coming in to work for the staff, when the visitors are coming in. So we're screening them, asking them about the status if they are sick, and we strongly encourage them to stay away, go back home, wait till they're better. Steps that we're doing to help prevent the spread of these infections, we're strongly recommending flu vaccine for all of our staff, as well as on a yearly basis, as well as follow-up for COVID and RSV vaccines as recommended. We also strongly encourage use of a mask, especially if areas are crowded or there's high-risk complications from COVID, flu, or RSV, which is respiratory syncytial virus. And again, we're strongly encourage visitors and staff, if they're ill, stay home. If you must go out, use a mask. We encourage people to wash their hands, sanitize with alcohol-based products on a regular basis. You keep your immune system healthy by doing a healthy living lifestyle. And again, stay home if you're sick. We also encourage them to contact their primary care provider if they're experiencing any symptoms of COVID, flu, or RSV. Next slide. This goes over a little bit of the detail of the infections, respiratory virus infections we've seen in California. The map that's on the far left is the influenza. So you can see there's a Central County, very high risk of influenza. The middle section refers to respiratory syncytial virus, which for some reason tends to be a little bit more in Northern California. And for another unclear reason, we have very low COVID infection, at least so far in California. I'd like to think it's due to our vaccine rate, uptake, but still hard to say. The status can change at any time, especially with different environmental conditions coming along. And we strongly encourage people to update their vaccines as needed, and to also consider protecting anybody that's around you when you're getting a vaccine, so that you might protect somebody who's more ill or potentially more ill. By getting a vaccine, you're less likely to take that virus infection home to your family. Next slide. This goes over a little bit of the influenza COVID prevention for 2026 that we're doing. So we're doing screening admission mostly for hospital patients and testing based on symptoms of COVID influenza in the ED and also prior to admission. We're doing immediate isolation of anyone who's symptomatic or considered high risk. We're strongly recommending masking and use of PPE, personal protective equipment. We also have a safe visitor policy, again, strongly encouraging if they're ill to please stay home. We also do screening questionnaires for all elective surgeries. On the right hand of the slide are our safe practices, which is eye protection within 6 feet of patients with suspected respiratory infection, increased frequency of surface decontamination, and environmental cleaning. So we're suspecting that there's an increased frequency of any of the infections. We're doing more decontamination and environmental cleaning. We're consistently using personal protective equipment, which is, again, gowns, gloves, and masking. We're communicating and planning with local skilled nursing facilities and public health departments to help us evaluate anything that's ongoing. Because many of our patients do get transferred to the skilled nursing facilities, so it's very important that we keep in contact with them to know what their status is as well. We're also adhering to any respiratory etiquette or hand hygiene. So if someone is coughing, we sometimes recommend that they cough into their elbow. And from my standpoint, you can't wash your hands enough. We also follow national standards for healthcare worker safety. Next slide. This goes into a little bit of different information that Mary had brought up about Clostridium difficile, which we abbreviate by calling C. diff. So on the far left, we'll go through what is C. diff. It's a very contagious bacterial infection. Many times it's within our gut system ordinarily, but it's because we have normal bacteria that are in our system, it's under control. It's when we see use of antibiotics that come through that affect the normal bacteria in our system, and those get suppressed was when we start to see the C. difficile becoming more prevalent. So the steps at Washington Health that we are taking is we did a C. diff prevention campaign, which was established in 2016 and continues still. We do nursing and lab timely identification of diarrhea and testing so that we can see if a patient has C. diff. Our infectious disease consultants are very appropriate in trying to recommend antibiotics which are appropriate for the patient and to make sure that we're using the right dose and the right duration for the right indication. For pharmacy, they do what we unfortunately call bug drug matching for best infection treatment. So when we see a patient with a particular type of infection, such as bladder infections, pulmonary infections, that we're matching the antibiotics, the drugs that are best suited for that situation. Environmental cleaning is very dedicated to making sure that we have a clean environment, both for our staff, visitors, as well as our patients. So we have a specialized team for cleaning of these C. diff rooms. We also include infection prevention education, surveillance and isolation precautions, and the information that we provide to our staff, visitors, as well as patients. So prevention-wise, during hospitalization, we're strongly, again, recommending that you wash your hands before entering and leaving rooms. We prefer hand washing over alcohol-based, but generally whatever's available is appropriate. If you're a patient with C. diff, then we strongly recommend that you stay in the room and not go out into the common areas because it's very usual that this can spread fairly rapidly. We also encourage you to talk to the nurse if the patient that you are planning to visit might have C. diff, because we have special requirements that the visitors also wash hands, use gowns and gloves. And we also strongly encourage no drinking or eating inside those patient rooms. So at home, what can you do? Again, wash your hands. Frequently wash your hands at least 20 seconds, which is counting 1,000, 2, 1,000, 3, 1,000, up to 20, 1,000. That'll give you your 20 seconds if you want to count it, or you can set a timer. It's particularly important after using the bathroom and before preparing any food or eating that you wash your hands. We recommend that you clean and disinfect with bleach because that's more effective than some of the other disinfectants, and also wear disposable gloves while you're doing cleaning, especially bathrooms, so you can get rid of them. We also recommend that you change and wash linens with hot water on a regular basis for any patients that have C. diff. For treatment of C. diff, take only the antibiotics that are prescribed by your physician, your healthcare provider. So it's the right dose for the right duration. I would also encourage you to notify your healthcare provider if you suspect that you have any symptoms or have been in contact with someone who might have C. diff. And I think it's very important to look at the blue bar at the bottom. C. diff infection ratio in 2025 for Washington Hospital was below the benchmark, which is a tremendous positive for our hospital. Because when you're above it, you have more contamination. When you're below it, you're much better. This is a slide on tuberculosis surveillance, which is another illness that we screen for because many people are often unaware that they have this or have been exposed. So tuberculosis is a communicable disease that's caused by a bacteria that attacks the lungs and other body parts such as kidney, spine, or brain. The steps that we are taking at Washington Health is to make sure all of our employees are screened annually. We have a collaboration with Alameda County to monitor the incidence of infection. We're screening all patients who are suspected or confirmed based on their history. Nurses are initiating airborne isolation for suspect patients until we can either confirm or rule it out. We do continuous negative pressure monitoring in the isolation room. So this is basically making sure the pressure in the room goes out to the environment rather than going back to recirculate in the hospital. A diagnosis made after MD consult and laboratory confirmation is done through Washington Hospital. We also coordinate to ensure that the care, medication, and follow-up for these patients is maintained. We do discharge education when the patient's being discharged or released to make sure that they know what levels of care and medication management that they need to continue. This is also very critical with some of our nursing facilities so that they know what's going on, and also for family members so they are updated as well. Staff education is required to complete infection prevention education at the time of hire or annually. We do ongoing just-in-time education during huddles, such as if we have patients with C. diff or some other resistant infections. We also provide educational material for infection prevention website, which is what you're seeing on your right-hand side, which goes into detail about what to do, how to do hand hygiene, how to do masking, how to do donning your gowns. We also have an annual employee health and safety fair that we participate in to share some of our information. Next slide, which will be, this is my last, you'll be relieved. Future compliance with healthcare associated infection reporting is done in line with the Centers for Medicare and Medicaid Services, CMS, as well as through CDC. We have ongoing comprehensive multidisciplinary infection rounds where our infectious disease team with Anusha and Shivali go through different units to help disseminate information and build up education and do observations. The data is reported quarterly to our Clinical Evaluation Committee, to the Nursing Oversight Committee, the Pharmacy and Therapeutics Committee, medical staff meetings, which are several, and Multidisciplinary Infection Prevention Committee. We try to sustain improvement in preventative initiatives, including those of C. diff especially, but also including catheter-associated urinary tract infections called CAUTI, which Mary mentioned, as well as central line-associated bloodstream infections, also called CLABSI. For future preparation for outbreaks, we are working on surge and other management directives. That's my last slide, and I'll take questions.
Thank you, Dr. Martin, and thank you, Mary. Any questions for the two of them? I appreciate the update, and let's hope 2026 is a great year for infection prevention and antibiotic stewardship and keeping those C. diffs down where they need to be.
Well, we truly appreciate the support from all the nursing staff and administration because it's definitely a team effort. It's not one-sided by any means, but also trying to include patients and families as well as visitors so that they know what to expect. Thank you. Thank you.
Thank you. And thanks for all of your ongoing support for our program. Thank you.
Thank you. Okay, we'll now move on to our finance report, Arthur.
Thank you, Dr. Nicholson. So my comments today relate to the month of December and the fiscal year to date through December 25, 6 months. And as you can imagine, that also triggers as we go into the new year budgets and things like that, and the whole team, not only the finance team, but everybody is now deeply into the budget. But before we commiserate with them on that, let's go through December. And December was a busy month for the hospital. Our patient days were about 57, 78, a little bit behind budget. On a year-to-date basis, we've got about 31,590 patient days, 2,100 below budget. But just to put it in perspective, that's 2,168 higher than last year. So the place is busy. We budgeted probably a little more aggressively. On the discharge side, we've been doing higher discharges, 1181 versus a budget of 1154, 27 higher. And on a year-to-date basis, we're 125 discharges higher than budget. Our observation, the trend that we've been seeing for the last year or so continues on. Our observation days are lower than budget and lower than on a year-to-date basis. And also the trend on an average length of stay, that has continued on, which is great news. We'd budgeted 5.22. We actually had a length of stay of 4.83. Now, all these stats Kimberly had covered at the meeting last month, so I won't go into a lot of details, but certainly happy to talk about them if the board would like. The CMI was a little lower than budget. Deliveries were right on target. Surgical cases were a little below budget. Cath lab cases a little below budget. Outpatient visits and ED visits were a little below budget, but all relatively higher than last year. In the details related to the surgical areas, although the surgical cases were 33 below the budget, majority of the areas were either close to budget or higher, other than orthopedics, which particularly related to people taking some time off and things like that. On the cath lab, similarly, overall we were 21 cases lower. The majority of it came from the cardiac side, and I think that was also due to time off and things like that during the holidays. Moving on to the FTEs, good story there. Our FTEs were on total FTE basis were 173 below budget, and on a year-to-date basis, almost 90 plus under budget. And on a FTE per adjusted occupied bed basis, we were 4.1% below budget, so that's good news. On our, moving on to the dollars and cents here, gross charges were, for the month, were $8.7 million below budget. But on our provisions and our contractuals, we were roughly that much, that priced out better by $8.3 million. So as a whole, it sort of, those two washed out, and our deductions as a percentage of revenue were about 75.8 versus 76.5%. On a year-to-date basis, somewhat similarly, we're $20 million gross patient revenue behind, and our contractuals are about $17 million below budget. And just compared to last year, our gross charges are $53 million higher than last year. And we're growing in a lot of the areas that you actually saw presentations today: cardiology, services, those kinds of things. Moving on to the operating income, you can see here our net operating revenue. As I pointed out, with our contractuals being offsetting the lower GPR, our net operating revenue was $59.6 million against a budget of $59.8 million, so pretty close to budget. Our operating expenses were $1.7 million better than budget. As a result, we ended up with an operating income of $2.8 million against a budget of $1.2 million, which is really great news. This is, I think, the first month here that we really had a nice positive income. And as you go down there, we have a net operating income of $7.5 million. A majority of that, and the budget was $1.2 million. The differential is the foundation donation that came earlier this year. Usually they were budgeted to bring it in January, but we moved it up to December. Thank you to the foundation for doing that for us. As a result, our net income for the month was $10.3 million against a budget of $2.4 million, 17.2% versus 3.9%. On a year-to-date basis, our net operating income is a loss of $2.8 million versus a budgeted loss of $4.8 million, so we are $2 million better than budget. And on a net income basis, we have a profit of $10.9 million versus a budget of $2.3 million, $8.6 million better than budget. I will skip the FASB side and just point one more thing before I wrap up my presentation, and the EBITDA. That's strong EBITDA this month, $6.3 million against a budget of $4.75 million, about $1.6 million ahead of budget. And on a year-to-date basis, $18.7 million against a budget of $16.5 million, higher by about $2.2 million. Overall, very decent month financially, and I know Kimberly is going to talk about the activity in January next, and hopefully.
Any questions for Ajay? I have just one question, Ajay.
Yes, sir.
The provisions for bad debt and charity were less than expected.
Yeah.
I'm a little surprised at that, given the potential loss of insurance from changes in healthcare insurance markets.
Yeah.
Are we just not seeing it yet?
Some of it is, there's also, it depends on how much we've provisioned before and how that's playing through. So this is, I mean, at the end of the day, for the year, we're about, we've already had $24 million worth of provisions.
Mm-hmm.
So, this is a tough one to budget because it depends on, what's showing up and how. So I think we may have budgeted to expect a little more of that hearing when we were going through the budget and OBB and all of that, and that's coming a little slower than what we'd expected. So
It's good to see that it hasn't hit as hard.
Yeah, but that doesn't mean it won't hit.
Well, we understand that, we understand.
Yeah,
that.
because the subsidies for those who were on the ACA, got insurance through accountable care at the state level, that just went into effect as of January 1st. So people were just seeing those huge subsidies, not happen.
So that's a piece of it.
Yeah.
A piece of it was the Medicaid.
Right,
and
that's the other side that's happening.
So there's a lot of this, and it will change. This will change over
The good news is strong performance and the increased EBITDA, and EBITDA creates opportunities.
That's a reinvestment.
All right, I'm going to, as Ajay said, talk about January. We had another very busy month in January and some, highs for the last 13 months in terms of it. So you can see with our patient days starting for January of 2026, they were favorable to the budget by 3.1% and also favorable to January of 2025 by 12.2%. One of the things that is impacting this, we had a number of long length of stay patients that were discharged, and so those days actually hit this month. But overall, our patient days were high, but if you look to the next, our discharges were also above budget by 4.6% and also favorable to January of 2025 by 16%. So again, continuing to see that volume increase. As mentioned, we had 10 patients discharged in January that had stays over 30 days. They ranged from basically 31 days all the way up the highest with 81 days from that. Also, just at the beginning of February, we still do have 9 patients who have been in-house for over 30 days, with the longest being 129 days at that time, and then followed by 85 and 81. So we do have some longer lengths of stay here for various reasons, and medical too, from that standpoint. Moving on to our inpatient average length of stay, it came in for the month of January at 5.07. It's favorable to the budget of 5.22, and also favorable to January of 2025. But as we can see from the previous months, it is higher than we have seen, and a lot of that is driven by those long length of stay discharges, as I mentioned from that. I'll also be talking a little bit about the case mix index, and so if you turn the next, you can see the CMI. It did increase. We talked a little bit about it last month. We had seen it go down some. We did see an increase, and again, this is just 1 month, but there are a number of factors impacting this, and as I've mentioned, we have an initiative around our revenue cycle, and one of those is to have, we've brought in some additional clinical documentation specialists that have helped us to do more concurrent reviews with more of those charts and everything. So that has really helped us in terms of being able to review on a concurrent, timely basis those charts, and then work with our physicians to ensure that all documentation is captured appropriately. So again, this is just 1 month, and so we will see that we did see that CMI tick up. Moving on to our inpatient average daily census, it came in at 205.6, which was favorable to the budget of 199.4 by 3.1%, and also favorable to January of 2025 by 22.4 equivalent days. Also, it was our year-to-date inpatient average was unfavorable to the budget of 185.5, but favorable to last year's year-to-date. Again, with our outpatient observations, we continue the trend and have continued the hard work in terms of ensuring that our patients are in the right level of care. And as Ajay mentioned, the initiatives have continued in January. Surgical trends for the month, we had total surgeries at 585. That was a busy month. It was the highest volume in 13 months, but it was just below the budget of 593 by 8 or 1.3%. So just under the budget. Year to date, we were basically consistent with budget. Inpatient surgeries were favorable to budget, and our outpatient surgeries were just under budget by about 10%. We also had 3 TAVR cases, and as Dr. Beggy and Dr. Argawal talked about that and how that program continues to grow. You can see in the surgical activity, the breakdown. We did last month, and you could see in December, neurosurgeries were very high. I think we had 41 this year, or this month it was 10 under budget. We did have a very busy orthopedics month, and that was a lot tied to our trauma volume that you'll see. Our UCSF surgeons were very busy, and then also other, which was really focused on gynecology and ENT, both being under budget there. Cath lab, good budgeting for the cath lab. It was right on budget. 217 cases, and year-to-date cases are also favorable to the budget by 62 or 4.5%, and favorable to last year's year-to-date too. Inpatient cases were favorable to the budget by 8.3%, and outpatient cases were unfavorable to the budget by 10.3%. So we got to right on the budget in terms of that. We did do 7 mitral clips and 3 Watchmen in January. If you look at our cath lab activity, that basically in terms of interventional radiology, it was down by 2 cases. As you know, we have a new group in here, but they have been very busy. So I feel like just in terms of sort of the activity, they've been working really hard in terms of that, and doing other types of biopsies and imaging. So not all their work is necessarily focused on the cath lab. Also, neuro IR was also down about 4 cases. So this was what's driving it. Deliveries was one of our areas that was much slower this month. I know we're looking into this a little bit more, but we had 113 deliveries for the month. It was under budget by 24%, and 19.3% unfavorable to January of 2025. We did have 1 twin, so we actually had 114 babies and 113 deliveries, and our C-section rate was 24.8. So not bad in terms of continuing to look at that. Yes. Non-emergency department outpatient visits were unfavorable to the budget by 5.4%, and unfavorable to January of 2025 by 3.4%. Imaging was down by 8%. Lab visits were down by 4.4%, but I do want to say that was the highest monthly volume that they'd seen in 13 months. So again, we had a high number. One of the areas, though, that we've struggled with is lymphedema. We had one of our therapist in the clinic was out on vacation, approved, and then another one had to go on emergency leave. And unfortunately, these therapists are very hard to recruit, and we are continuing to look at ways, and we're actually going to be training some of our own in terms of this. It takes some time, but it is an area that's important, especially with our cancer program, and we realize that. And so, unfortunately, the lymphedema clinic was closed for a period of time in January, and so we're open again, but again, we know we've got to do some more training. So that was one of the areas it was 62% based, or 61% below budget. Outpatient wound and EKG were over budget. Looking at our visits for the emergency department, they came in at 5,398. It was unfavorable to the budget by 4.6%, and down from January of last year at 5.3%. I will say, and you will see, we had a very high trauma volume for the month, and we did see higher level 4 and 5 visits compared to the other months too.
Do you think any of that impact is due to the urgent care?
It is hard to see. It's hard to say right now. You know, we came in a little over 600 visits for urgent care. It could be we were a little bit lower, but it's hard to say. 1 month is really making making that in fact. I know that was asked, but we'll have to see. Looking at our total gross revenue, came in at $260.1 million for January, which was favorable to the budget of $255.3 by 1.9%, and also favorable compared to January of 2025 by 7.6%. So continue to see that revenue growth, and it is the highest monthly gross revenue in the 13 months. January's performance was mainly driven by higher inpatient gross revenue at $5.8 million, but was offset by lower outpatient gross revenue of about $1 million. And we'll take a little bit of look at that. So if you turn and you can see with the next is our preliminary inpatient gross revenue. That was favorable to the budget, came in at $164.1 million, and was favorable to the budget by 3.7%. It was also higher by 14.1% than January of 2025. Also, our year-to-date inpatient gross revenue was unfavorable to the budget by 25.2 or 2.5%, but favorable to last year to date by 9.5%. So again, a busy month, and you can see with our outpatient gross revenue. Came in at $96 million, which was unfavorable to the budget by just by $1 million or 1%, and a lot of this was in terms of due to less observation days, and it was unfavorable to January of 2025. And some of this was driven by the cath lab services in terms of outpatient being below budget and observation units. Moving on to our gross revenue recap. As you can see, surgical services revenue was unfavorable to the budget by just $112,000 or 0.3%. Though we were down 1.3%, but just with the case mixes for surgical services. Cath lab services was unfavorable. I know we talked about coming in consistent with the budget in terms of the volume. But we do go by post date for coding. There is a lag in coding cases towards that end of the month. So, we will pick those up in next month from that. You can see that room and board was up. The other area, emergency department, just given the acuity, even though volume was down, we did see a higher acuity in the emergency department. So that did drive up the revenue. But overall, we were above budget by 1.9%. As I mentioned, trauma was very busy for the month. It was one of the highest volumes we've seen since opening, and also basically was favorable to the budget. We came in at 209 cases, was favorable to the budget by 24.4%, and was favorable to last year by 40 cases or 23.7%. Our inpatient trauma cases were favorable to the budget by 53.4%, and outpatient trauma cases were also favorable to the budget by 10 cases or 9.1%. And one of the things I know we've been talking to the county about, the high volume of trauma cases is seen throughout the county. It's not that there's any shift of volume from one hospital to another. All of the county has been seeing over, between 9 and 10% increase in trauma overall, which is a trend that is being seen across the United States too. So, more education that we need to do in terms of, because as you'll see, falls continues to be one of our highest volumes. So, looking at the types of cases by activation code, as you can see, we had the highest number of alpha cases coming in at 20, which is our most highest acuity of patients, followed by 50 Bravo and 139 Deltas. As I mentioned, in January, out of the 209 trauma cases, we had 135 falls. We had 45 motor vehicle crashes, 11 other types of cases like scooter stabbings, lacerations, 8 bicycle cases, and 5 pedestrians and 5 assaults. So that's the breakdown. So we continue to see those falls being the highest types of cases we're seeing. Just given the acuity and the number of trauma cases, our trauma gross revenue came in at $30.4 million for January. That was favorable to the budget by $18 million. A budget of $18 million by $12.4 million, or 69%. So it's also favorable to last year by 47.2%. And again, you can see it's the highest monthly gross revenue. Our inpatient gross revenue for trauma cases was 23.2, was above budget by 69%, and outpatient trauma gross revenue was favorable to the budget by $5 million. That was $5 million, or 41%. Here is the preliminary payer mix. We've also added year-to-date, so you can kind of understand overall year-to-date where we stand. In terms of government payers, looking at for the month, we're unfavorable to the budget by 0.9%, with Medi-Cal being favorable by 4.3%, and Medicare unfavorable to the budget by 5.2%. But year-to-date, overall, we're consistent with the budget. In terms of HMO, very much consistent. PPO was, in terms of for the month, down by 0.7%, but both self-pay and TRICARE were consistent to the budget. As mentioned, it was a busy month, and so our productivity was strong. We had productive FTEs for January were favorable to the flex budget by 100, or 6.5%. And our productive FTEs for adjusted occupied bed came in at 4.73, which was favorable to the budget by 5.12. Our non-productive was just consistent, right on budget, consistent with budget by 1, or 0.4%, at 244 FTEs, and favorable to January of 2025 by 33, or 12%. Our total FTEs for January came in, compared to the flex, were favorable to the budget by 5.6%, and came in at 1,783.4 FTEs. Our total FTEs per adjusted occupied bed came in at 5.47, which was favorable to the budget of 5.88 by 6.8%. So overall, again, a lot of it had to do with how busy our volumes, in terms of that. Moving on to Radiation Oncology Center and our treatments. We came in at 193 treatments for the month of January. It is unfavorable to the budget by 167, or 46.4%. We've talked about this in terms of just the number of treatments per patient has reduced. We are seeing a little bit slower of the number of patients that we're treating, but it is seeming to build back up, and some of that is just we're seeing that patients are taking longer in terms of whether they're getting surgery first or making decisions of to wait. We're seeing a number of things, but we are continuing to watch this on a monthly and year-to-date. As you can see, sorry.
Are you going to be revising your
yes, we will.
Criteria for
exactly.
This particular line?
This will be looked at in terms of just really
methodology.
Exactly, and we work very closely with UCSF on their protocol, so it's very much aligned with what they're seeing. But absolutely,
when clinical things change, we've got to.
Yes, and so we will, as Ajay said, we are budgeting in the midst of budgeting, and this will be one of those things that will be taken into account. When you look at the consults, we saw 32 new referrals to the clinic, and so in terms of our conversion rate is about 22% for January. So we're continuing to look at that and ensure that we're seeing the referrals that we need to see. Looking at our outpatient statistics for Washington Health Medical Group, we did come in unfavorable to the budget of 1,845 by about 10%. One of the things, there are two main driving factors. In specialty care, they were unfavorable to the budget by 9%, and that has to do with two provider resignations, one in ENT that we've seen that we're recruiting for, and one also in women's health. But the other piece that we're really focusing on in terms of primary care is our nurse practitioners and our physician assistants. And really, we've opened up their schedules and had budgeted the more visits for them in terms of coming in there. And we've just got to bring more awareness to our community about being able to see our nurse practitioners and our other advanced practice providers. They're very strong. We've hired some very strong individuals that work very closely with the primary care physicians. And so it's an area that we're both working with the physicians and with the community to bring that awareness. And that's really what's been driving on primary care, that decrease. So that's one of the initiatives we're focusing on. So it's going to take some time, but that's we've had a lot of discussions about it this month. All right, moving on to our urgent care. As you can see, we came in at 635 visits for the month of January. They were unfavorable to the budget by 33.9%, but I just want to remind you, this is our first full month of seeing patients, and so we had budgeted to start in November, but as you know, we opened December 17th, and so we feel we're trending in the right direction, but we're also continuing to look at ways to open up the schedules, be able to get the word out about we take walk-ins, and you can go online and schedule appointments, but also please walk in. So we've been talking about it in many different venues, so we're really working on looking at getting the word out. Moving on to Development Corporation, the outpatient visits of 2030 were unfavorable to the budget by 11.9% for January. In terms of the three areas, Washington Outpatient Rehab Center was unfavorable to the budget by 1.1%. We did have some of our physical therapists out on sick leave, and a higher number of cancellations that we're working to get that back. Also, in terms of surgery centers, the Washington Outpatient Surgery Center was below budget by 13%. This was driven by both ENT cases. As you know, one of our ENT physicians left, but also gastro GI cases were lower this month. So those two were driving that. And then our Peninsula Surgery Center was also under budget by 18%, and that's mainly in the area of pain management. We did have one of our pain management doctors leave, and we also have one that's out on personal leave. So that's one of the main drivers. I think that's an area that we're going to have to look at doing some recruitment on. Looking at our key statistics for January, our days cash on hand remained consistent at 110 days. We did see, I know we just had a discussion a little bit about charity care. We did see a little bit of an uptick in total, $353,000 for charity care, higher than the rolling 12-month average of $209,000. However, all of this is fully reserved for us. So it was, as mentioned, a busy month in terms of the statistics, and so Ajay will be bringing to you the financials next month.
Thank you very much, Kimberly. Any questions for Kimberly on this? All right.
All right, just a couple more things. I do want to talk about Employee of the Month, which is Gary Tran, and he is our February Employee of the Month. And he is the service line coordinator, mainly focusing on robotics in our operating room. And so Gary has been part of our health system for several years. He's been working as the manager of the Washington Outpatient Surgery Center for many years, and then he joined our main hospital in December of 2024 and has basically had an immediate impact on the operating room and really the work environment with many of his colleagues. From day one, Gary's calm, positive attitude and approachable demeanor has spread through the workplace. He has quickly established himself as an invaluable asset to our organization. He has played an instrumental role in several major initiatives, including the Da Vinci robotics program, our trauma readiness efforts, and most recently the launch of our intuitive Ion robot. And we will be seeing our first patients on Ion this next week, so I'll talk about that next month. Beyond these measurable accomplishments, where Gary's impact is most strongly felt is in his day-to-day interactions with his peers, his physicians, other physicians, and most importantly, with our patients. Gary approaches every task with an unwavering commitment to excellence and a genuine sense of purpose. Regardless of what is asked of him, he does it with a smile, never questioning why something needs to be done, but instead asking, how can we make sure we get this all done? That consistent glass half full mindset has earned him the trust and respect of physicians, colleagues, patients, and the OR leadership team alike. He was recently recognized as a department rock star. Some of the comments from his coworkers included, he is always willing to teach, guide, and uplift those around him. Gary's commitment, energy, and leadership deserve to be celebrated. Another comment is Gary is a phenomenal coordinator and is always in the room to help. He has excellent insight on cases in his service line. One last one is he's always willing to go the extra miles to help with a positive attitude. And one example of that extra mile occurred when a post-op TAVR patient began to have issues and when extreme measures were required to save the patient's life in the CCU. Many critical supplies were not readily available, and Gary stepped up to coordinate efforts to gather the necessary supplies, running back and forth between the OR and the CCU. Gary's effort that day was pivotal in helping the team proceed with the life-saving procedure. Very much embodies that all of our values. Yeah. All right, now we're just going to scroll through a lot of our calendar for the month of February.
Fall prevention.
Yes, fall prevention is right. It's important. These are some of our ones, and you can see the views that are listed there.
You can see Dr. Khan has grown a beard.
Yes, and here are some of the other ones that occurred in January and the beginning of February. These are our upcoming ones, and again, you can find them on our website if you're interested in getting more information on them. Just want to mention in terms of the foundation, very much appreciate all of the work that the foundation does to help to support the health system. And as you can see, they dispersed over $6 million to the health system, and really that partnership is invaluable to the work that we do. And so really appreciate all the work that the trustees and everybody associated with the Washington Health Foundation does for us. And this really is a listing of, on an annual basis, they do the disbursement, and this is really an overview of all the areas that they help to fund, and it really makes a difference in so many areas, everything from technology, equipment, all the way to scholarships, trauma program, everything is really encompassed, and they really make a difference. I want to thank them. All right.
All right. Kimberly, any announcements?
No announcements.
All right, very good. Any questions or concerns from the board members tonight? No. All right. There being no further business before the board, this meeting is adjourned. Thank you. Have a wonderful Valentine's Day.
Thank you. Yes. Right.